I think the relevance of our study is that the PLCO released their data publicly for reanalysis or for secondary analyses, and so we had the opportunity then to question, well, how come there are some other studies that said the contamination rate in the control arm is higher than 52%, and why did the study design, which was very similar to the European study, why was one study negative and the European study positive? And so getting to what we found, basically, the goal of a randomized trial is to really compare apples to oranges. You have your intervention group, which receives PSA testing. You have your control group that was not supposed to receive any PSA testing. And so rather than what we found by going back and looking at the surveys that they used to assess PSA testing was that close to 90%, in fact, of the control arm that wasn't supposed to get PSA testing actually got PSA testing cumulatively during the study period. And in fact, in later years of the study, the amount of PSA testing in the control arm was greater than the intervention arm. So rather than comparing apples to oranges, you really were comparing, if you'll allow the pun, lemons to lemons here, because it was really a comparison of very similar exposure to PSA testing in both arms. So our hope is that the task force is reassessing the utility of PSA testing in men's health, and that with the evidence that we've provided in terms of the previously unrecognized severe limitations, that I think that the PLCO study is uninterpretable, and therefore we have to look at the randomized trial findings from Europe as well as the epidemiological data in the United States that has shown a decrease in prostate cancer specific mortality as well as a reduction in lymph node or metastatic disease in general that's occurred after the adoption of PSA testing.